дорогие коллеги,
Good
огромное спасибо.
afternoon, dear colleagues. Thank you very much for joining us today. This is the 11th virtual webinar in the framework of the regional operational study on treatment of rifampicin-resistant tuberculosis. We are having a very special topic today. This is treatment of tuberculosis in prisons. And during an hour and a half, we'll share the latest data on epidemiology of tuberculosis in prisons of the WHO European region. And we'll talk about the current realities and about the fact that the new drugs are now available only in the framework of the operational research. And we'll talk about the implementation of operational research in prisons in general, and we'll give you an example of Azerbaijan. I would like to remind you that uh, we have interpretation available. You can choose either Russian or English, and you can choose the function of interpretation. At the bottom of your panel, you can find the globe symbol where you can choose the right language for you. And I would like to remind you that all presentations today are available in the cloud, and you can go there and download the presentations. You will find that link in chat. Once again, I would like to ask all of you to ask questions, to be active during our webinar, because the topic is very special today, and we invited um, mm, a number of speakers. One of them is the representative of um, the Red Cross Committee, and you will have a chance to ask questions. So use this opportunity, ask your questions in chat, and we'll try to raise those questions during the webinar or afterwards, um, unless we do not have enough time during the session of answers and questions. And now I would like to give the floor to dear Dr. Askar Yedilbayev from WHO Euro, who will make the opening of our meeting. Elmira, thank you very much. Dear colleagues, uh, good day to all of you, and we are glad to welcome you at the next 11th Virtual Medical Consilium webinar organized by the WHO. And we hope very much that this kind of activities help you in your everyday practice and in the implementation of the regional operational research on shorter treatment regimens for treatment of tuberculosis. As Elmira has noted, our webinar today will be focused not so much on clinical aspects, but some programmatic aspects of tuberculosis. Nowadays, we can say that TB knows no borders. That's why a discussion of treatment of tuberculosis in vulnerable groups of the populations who often receive medical assistance with some delay compared to the civilian sector is very important. We'll be talking about the access to the new drugs in the framework of programmatic activities and operational research. Not all countries that participate in um, mSTR research expand their activities to the prison sector, and hopefully today we'll talk about it during our webinar. Without any further ado, I would like to welcome all of you and to thank our speakers who agreed to take part in our meeting today. And let us start the webinar. Thank you very much, Askar. And now, without any further delay, I would like to introduce our first speaker. I think all of you know this speaker very well. This is Dr. Andrei Dadu from WHO Europe, who will share the results of the study implemented under his leadership, and these results were published in the international journal. Thank you very much, Elmir. Um, Dear colleagues, I would like to say that the group of researchers was quite big, and all researchers contributed to this analysis. So I cannot say that this work was done under my leadership per se, but this work was very interesting and it was very important. And we analyzed the data received from the entire region. This kind of work has never been done before, and hopefully at the global level or in other regions, this standardized approach will be used. So we used this approach for the cohort analysis, and hopefully it will become a routine practice. So now I will share my screen with you. I experimented a lot, and part of my presentation is pre-recorded and part of it will be live. So let's see how it will work today.
Okay. Okay.
Все видно.
Добрый день, коллеги. Меня зовут
Good
Андрей
afternoon, dear colleagues. My name is Andrei Dadu. I'm an epidemiologist and I work in the WHO Euro. And I would like to start my presentation with the words of thanks to the Secretariat of the Virtual Medical Consilium for an opportunity to present this information. And to tell you about the results of comparative analysis of TB incidence and treatment outcomes reported in the penitentiary and civilian sectors in the European region of the WHO. Also, I would like to thank the group of co-authors who contributed a lot to this analysis. And I also thank the national counterparts from the National TB Control Progress and penitentiary sector in the countries for sharing the data that will be presented today. I will turn my camera off so that you could see the content of the slides, and we will continue.
Да, далее, при той цели, которая была представлена вам в предыдущем слайде, что было, в принципе,
So on the previous slide, you saw the objective of our work, and we followed three main goals. We described the differences in TB incidence in two different sectors, civilian and penitentiary sectors, between 2014 and 2018. We also assessed the relative risk of development of active tuberculosis among inmates as compared to the relative risk reported in the civilian sector. So when we talk about inmates, we talk about people in the detention centers and prisons. The third goal was to describe treatment outcomes in the penitentiary and civilian sectors. This kind of analysis of these very big cohorts has never been done before, and this is why this work is completely novel.
Да, как мы построили нашу работу, в принципе, изначально мы определили, что это
So initially, we decided that this
не будем, не утруждая вас
will
дополнительно
be a retrospective,
чеком
descriptive study,
процедур,
and I will not go in detail.
уже представленные нам. Мы взяли весь регион, абсолютно весь регион, то есть 53 страны и, соответственно, содержание этих баз данных, которые у нас есть в глобальной базе данных. Мы взяли в учет новые случаи рецидивы туберкулеза и результаты их лечения в обеих секторах раздельно. И, соответственно, тут вам предоставлены также 3 основные критерии отбора, которые мы учитывали при определении данного анализа. Это страны, подающие, по крайней мере, один отчет о новых и рецидивах, как и в гражданском, так и в специальных секторах за этот период 2014-2018 год. Второй критерий – это было, по крайней мере, 2 точки данных, то есть 2 года, как и в гражданском, так и в специальных секторах, и страны, сообщающие о результатах лечения. То есть это 3 основные критерии, которые мы использовали для то есть включения записей в наш анализ. Источником, как упомянулось ранее, была в основном глобальная база данных по туберкулезу, куда стекается информация раз в год от национальных программ туберкулеза, включающих в том числе и раздельные когорты по тюремному населению.
So we use the global WHO system for data collection on prison population, on the number of new cases and relapses. At the time of notification. And also the data on treatment outcomes of patients who received first-line drugs. We used general demographic data from the global UN data on demographics perspectives, and we also collected and analyzed data on the number of prisoners from the global database for the description of prisons in countries. And if we did not have relative data available, we tried to look for additional sources of information. So by 2014, the countries managed to include in the national reports the data from the prison sector. It means that the prison population started receiving standardized treatment based on the national protocols for treatment of tuberculosis. 79% of countries of the European region of the WHO reported on the number of new cases and relapse of tuberculosis in civilian and penitentiary sector at least once a year between 2014 and 2018. And you can look at the map and see the graphic presentation of the situation. The results of the analysis are as follows. We could see a trend to a decrease in the number of new TB cases and relapses in the penitentiary sector and civilian sector. However, in the penitentiary sector, this trend was more pronounced than in the civilian sector, and it developed rapidly. So you can see that in the countries of Eastern Europe and Central Asia, that trend varied from 6% in Kyrgyzstan to about 17% in Georgia. And here we're talking about the incidence of tuberculosis among inmates. If we consider the burden of tuberculosis, about 7% of burden was reported among the prisoners. This proportion was the highest in the Russian Federation at the level of almost 10%, and in other countries it was about 1.5%. Here you can see the graph which illustrates the incidence rate per 100,000 population reported in the prison sector, and you can see that there is a number of countries highlighted red. The incidence was over 1,000 per 100,000 population.
Как видно на этом слайде,
as you can see from the slide, we tried to analyze relative risks for development of active tuberculosis in the penitentiary sector as compared to the civilian sector. And we could see that the relative risk was the highest in Slovakia, at the level of 57. It means that the prison population had the risk for development of active tuberculosis, which is 50 times higher than in the civilian sector. And the second highest relative risk was reported in the Russian Federation. The risk to develop TB in prisons was 25 times higher than in the civilian population. Now let's look at the cohort analysis.
У нас были данные из 74.
We received data from 74% of all countries included into this study, and we made the comparison between two populations, the prison sector and the civilian sector. Those were TB patients who received first-line treatment. So looking at the comparison of these two sectors, you can see that there are countries where successful treatment outcomes were much higher in the civilian sector. However, there are countries where successful treatment outcomes in the prison sector were much lower than in the civilian sector. So in 12 out of 39 countries, successful treatment outcomes among inmates were reported in more than 85%, was at the level of 85%. In Belarus, Tajikistan, Bulgaria, Latvia, Chernogorия, Montenegro, Romania, and Slovakia, more than 85% of favorable outcomes were reported in the civilian and penitentiary sector. In Cyprus, the Netherlands, and Kazakhstan, there was a high level of unfavorable outcomes reported for the inmates. And in conclusion, I would like to thank my colleagues from the research group, and I also want to thank the countries which provide us with the data on the regular data. And because of that data, we can implement this kind of analysis. The completeness of data was quite high. We worked on it for a long time, and I would like to thank our WHO Collaborating Center in Baku, which does a lot for ensuring standardized, good quality TB control services throughout the region. In our analysis, we highlighted the vulnerability of inmates to tuberculosis and the need to improve practices of TB prevention and treatment, especially in terms of active TB detection, infection control, proper TB treatment, and uninterrupted treatment, especially during transfers of patients between the sectors. In the majority of the countries, there was a significant decrease of TB burden in prisons reported, which is a sign of effective healthcare reforms implemented in the penitentiary facilities. Of course, treatment of tuberculosis in prisons should be priority for the healthcare, and it is important to ensure intersectoral collaboration between the civilian sector and the prison sector in order to end TB in the European region in general and in prison sector in particular. Of course, we would like to see the implementation of this kind of analysis in other regions as well, hopefully at the global level. Now the standardized analysis is included into the regional report of WHO Euro by default. And there you can find the tables with data for your attention. Thank you very much. And that was the end of my presentation. And I hope you found it interesting. Thank you very much, Andre. I don't see any questions in chat, but should you have any questions, dear colleagues, please use this opportunity and ask them in chat. I would like to say that in the civilian sector and in the penitentiary sector, we have been observing a decrease in the number of TB cases. However, we see an increase in the proportion of cases with drug-resistant tuberculosis, and that was typical for both sectors. We know that treatment of drug-resistant tuberculosis in the prison sector is especially difficult because it's a long-term treatment. And it is quite difficult to ensure continuity of treatment upon the release. And this is very important. If it can be ensured, that would lead to excellent results. But we see that not very many countries can achieve high levels of treatment completion in the prison sector, and the levels of treatment interruptions are quite high. That is why the role of shorter treatment regimens in the penitentiary sector is very high. We know that there are some effective all oral treatment regimens that could be used in our region, but nowadays then can be used in the framework of the operational studies. And now we see that the regional operational studies only in some countries can be offered to the prison population. In other countries, there is no such an opportunity for the inmates, which means that the principle of equal service is not being followed. And I would like to ask Elena Leclerc to tell us about it. Elena Leclerc is the coordinator of the International Committee of Red Cross on infectious diseases. She will join us from Geneva. And she will tell us about this marginal topic that brings together medicine and ethics. You will be able to ask questions during the presentation and after the presentation. Elena, the floor is yours. Elena will make her presentation in English, and so you can use the option of interpretation. But I will start in Russian. Elmira, thank you very much for the introduction. Oh, well, I don't think that it is absolutely correct that RCRC is the best source of this information. I believe that there are other international agencies and experts in the field of ethics and medicine, like the International or the Global Association of World Medical Association and other agencies. Thank you very much for the invitation to your webinar. I thank you, Elmira, and other organizers of this event. And so if you have any questions, I will be glad to try to answer them. And now it is time for my presentation. It will be in English, as Elmira noted.
Спасибо большое. Да, я начну с очень короткого введения о том.
I will start with a very brief introduction and tell you about the organization I represent.
That is why I will switch to Russian.
Today это Международный комитет Красного Креста, и с
International Red Cross Committee, and I switch into English. But it's very important to describe very briefly the activities of our organizations.
The Red Cross is the organization which is just a moment. I just want to minimize the slide. So I have an issue with techniques. Just a second. I want to remove this screen from here. Be patient. Can I just sorry for the technical thing, but okay. Well, I think I got it. I got it. I now I see the slide and I see the presentation. So thanks. So it's the ICRC is the impartial, neutral, and independent humanitarian organization which has a mission to protect the lives and dignity of victims of armed conflict and also other situations of violence, and to provide them with assistance. And at the organization, we have been visiting places of detention and monitoring conditions of detention since more than a century. It's almost about 100, well, it's more than 150 years, because the first visits to places of detention were done by the ICRC in 1870. So it's really a long history to working in detention. And when we are visiting places of detention, we are monitoring first of all the living conditions of detention. We need to ensure that they're decent, that they ensure also physical and psychological integrity of detainees, that they have access to food, drinking water, space, and of course adequate health care and hygiene. We also visit places of detention to ensure that detainees may exercise their rights, including the right to health. And of course, last but not least, it's on ensuring ending and preventing torture and other forms of ill treatment. So it's very much in a nutshell. It's really focused on what ICRC does in detention, because the organization has many other activities, as you may know, but I will not go into details today. But it's just again for you to link it and to link also the with the subject that I will be presenting, because when we are visiting places of detention, we are also looking at the ethical issues, and we want to ensure that the care provided to people in detention is in line with the current standard ethical norms and principles. So Elmira, next slide, please. Hopla. Okay, so all right, good. So I wanted to start this presentation to emphasize the key guiding principle for all health professionals that are working, be it in the community or in the detention centers, as it's stated by the World Medical Association Declaration of Geneva, which is in front of you, but it's also stated in the International Code of Medical Ethics that declares that a physician shall act in the patient's best interest when providing medical care. So this is just well-known principle to everyone who is in this room. And I just really wanted to start this presentation by emphasizing that, because it's a guiding principle of all medical acts and research in the places of detention and on prisoners. Next slide, please, Elmira. Okay. Right, super. So it's the medical research on prisoners. In the past, prisoners, they have been extremely extensively used in research. Why? Because it's the cheapest and the most available group of the population. And then because of the very specific vulnerabilities, which are very specific to the places of detention, also maybe to other groups of vulnerable populations, but in detention it's really it's extremely relevant. So it's the lack of autonomy and the lack of informed consent, and so not all the research that has been done on prisoners has been to the highest ethical standards, to say the least. And there are many bad examples, and I really don't want to spend this time on going through all of them. I mean, it's definitely, we don't need to even to remind anyone the examples of the Second World War, but not only, because there were several studies, bad examples in the United States in the past century, between 1932 and 72. It's a study on untreated syphilis in Negro males in the places in Florida. I can just cite some the same experiments in Guatemala. In the 40s. Then I would even talk about other US example. Unfortunately, it's about Philadelphia example on clinical non-therapeutic medical experiments in dermatology on prison inmates. Very recently in the Philippines, well, very recently not, I mean, it's a century ago, but it's still it's the most recent examples. So it's we can continue that, and that's not the point of this presentation. It's just to highlight how sensitive the topic is, and how much safeguards should be in place to avoid this type of practice. So the next slide, please, Elmira. Me. So I'm listing here. It's not yet. Yeah, super. So the list is not exhaustive, but there's current ethical standards and norms, and I will not read them all. I mean, but I will refer to some of them in a few minutes during my presentation. So as I already mentioned, it's the WMA Declaration of Geneva. We will come back a bit later in a minute, and the WMA Declaration of Helsinki, which has been amended in 2013, but originally adopted by the General Assembly of the World Medical Association in 1964. And there are other safeguards, norms, and standards that you can see on this list, and they're available I mean, for public on the intranet on their respective websites. So please don't hesitate to look into them more in details. Next slide, please, Elmira. All right. So here I wanted to zoom in on the 1988, the UN Body of Principles for the Protection of Detained or Imprisoned Persons, Article 2022 specific one, which is, as you see there, is stating that no detained or imprisoned person shall, even if with consent, to be subjected to any medical or scientific experimentation which may be detrimental to his health. So once again, coming back to what I said before, it's because of informed and competent consent in prisons is considered to be quasi impossible, then in the prison setting, autonomy can never and hardly be assured or never be assured. And so there is always this risk for health. So this article is sort of banning research the research on prisoners to protect prisoners. But then, and the next slide, please. But then they are evolving in the norms and standards, and again the let's say interpretation or principles, and we should admit that prisoners, they have specific needs in terms of ensuring their better management of their health issues, yes, but also if we ban the research of on prisoners, we will be violating the principle of equivalence of care. So as a general principle, prison inmates have the same rights to consent and to refuse involvement in research as the general population. So again, here we are ensuring the principle of equivalence of care. Prisoners are also entitled to benefit from research in innovative treatment in the same way as individuals in the community. They have the right to act altruistically through involvement in research projects, which, while carrying only minimal risk, might benefit others in the same category, even without benefiting directly themselves. And involving in research project can also have collateral benefits, like for detainees, and let's call it collateral. So improved health care and health outcomes. Also, it can contribute to a better or increased contact with medical professionals, and also closer monitoring of detainees' health conditions. So there are really some added values for detainees to participate in the research. But however, and again, I will repeat it, it's widely accepted that prisoners are a vulnerable group, and their confinement within punitive institution places unique stresses also on the relationship between researchers and the participants. And therefore, researchers have a special responsibility to ensure that the needs of this population group are taken into consideration when designing and undertaking the research. And now I see, I mean, the slide was already there for a while, but I still want to add something that well, this safeguard should take into consideration also all this and as far as possible the effect of prison conditions on the ability of prisoners to make autonomous choices. So this is really crucial. Now you can go to this next slide. Elmira will be finishing shortly. So traditionally, research has been divided into two categories, as you know. So we were talking about therapeutic research, which is combined research with an attempt to improving patient care, and then non-therapeutic research, where the aim was to gather knowledge. But then it was more recently argued that this distinction is really outmoded, and it was dropped. It was agreed as well that making the difference between these two were really blurred and unhelpful. So now the difference between innovative treatment and therapeutic research is also not self-evident all the time. So the aim of therapeutic research to produce new knowledge rather than to directly benefit the research participant, and innovative treatment, by contrast, involves the modification in established methods of investigation and treatment in order to try and improve the expected health outcomes. And this is widely regarded as being a standard feature of medical care. So, and I think this particular part is extremely relevant to the discussion that you have today, because you are talking about innovative treatment for tuberculosis. So this is, I see the very strong relations between that. But I mean, if and where in the situation when this innovative investigation on treatment is likely to involve either an unknown degree of risk for the participants or a greater risk than the intervention or a treatment that it is to replace. And again, I'm linking it with the tuberculosis now, with the new treatment that you are discussing, the new treatment protocols. Then a review should be thought from an appropriate research ethical committee, be it national or international. Okay, so here very quickly, so the key principles for medical research, the key issue is the balance. It's to protect the individual, but also to from all the let's say the exploitation, etc., and balancing the benefit for the individual, and the priority of individual rights also should be over the society. So it's just to keep in mind, and I repeat it again. So no harm principles, autonomy should be respected, and the informed consent of the individuals. And of course, the greater or the more direct are the expected benefits, the more risk can be considered, and vice versa. And the next slide here, just to summarize that key messages, that ethical norms, that the most, let's say, the recent standards and principles must be respected at all times. The need of independent review is necessary. All research involving human subjects must comply with the World Medical Association Declaration of Helsinki, and of course here it's on this slide I would also like to highlight and the focus on involving particularly vulnerable individuals who are the detainees. And I would like to conclude my presentation with really citing the WMA Declaration of Helsinki, which, and this is the next slide, Elmira, please. So this just summarizes all the elements that I have talked about. And you will find the full text on WMA website. And thank you for your attention. I think I'm done here, and then we'll be very happy to take questions if you have some. Thank you, Elmira, also for helping me.
Thank you very much, Elena. We have questions. Given that we have time allotted to you, we can voice several of them.
Здесь вопрос, если я правильно поняла, какая
If I get it right, what is the practice of mandatory treatment of TB in prisons?
Yeah. I will continue in English, Elmira. Is it all right?
Yeah, sure.
Well, it's okay. So this, I mean, it's not really clear for me, this question, but any forcible forced treatment is is unethical. So I don't know what you mean, Dr. Firuza, about this. What is the practice? But I mean, what is the principle and what is the standard? So no, there should not be any forcible treatment in the places of detention, as it should not be outside of places of detention. So there are no two different ethics. They are the same ethical principles as in the general community apply to the places of detention. So it should not be happening.
Огромное спасибо, Елена, я полностью поддерживаю.
Thank you
И
very much, Elena. I fully agree with you.
пока что других вопросов нету,
There are
только
no additional
благодарности.
questions, only
И
the words of thanks.
тогда я передам слово.
And no, there is a question. There is a question from Olga Demikhova. If a person doesn't want to get treatment voluntarily,
you know, I mean, I can give a very concrete example, and it will be very much relevant to what I mean to your to the group who is of people who are here today, because, and I will give us example of that we had in Kyrgyzstan as ICRC. We were working together, supporting the penitentiary authorities in Kyrgyzstan in fighting tuberculosis in places of detention for many years until 2020. What, of course, I mean, in this treatment institution, there were separations by different status. I don't need to go into details of detainees, and there were detainees who were refusing treatment. And it's not only in Afghanistan. We had the same example in Azerbaijan before, and my colleagues, they will just confirm. So that those patients who were refusing treatment, TB treatment, which is, they had a separate accommodation within this treatment center. They were isolated, they were separated. Of course, there were always the work done with them, and sometimes with the psychologist and the psychiatrist, and trying to convince them to take treatment, but nobody forced them to take treatment. And it was extremely relevant. And I remember those patients myself. They were suffering from multidrug-resistant or extensive drug-resistant tuberculosis. They didn't want to take the treatment any longer, so they were just accommodated separately in a very distant detention conditions, but they were not forced to take treatment, because once again, it's unethical to force anyone to take treatment against its consent. Any other questions?
Спасибо большое, Елена. Вот Ольга Демихова, я извиняюсь, я сразу не заметила.
Thank you, Elena. I see Olga Demikhova and then Aktay. Thank you very much. Good day, dear colleagues, dear Elmira. First and foremost, I would like to thank the organizers for such an interesting webinar and for all the webinars we had before, organized by WHO Europe, by our good colleagues, by Aktay, by Askar Yedilbayev. We are really grateful for the opportunity to participate. We are also grateful to our Moscow colleagues in our Moscow. I work at the Central TB Research Institute in Moscow, and we have a collaborating center. We've been having this center for more than 25 years on TB control in the Russian Federation. I'm impressed, highly impressed by both presentations made by Dr. Dadu and Elena. They are very interesting, beefy, topical, very relevant. And the numbers, for example, I heard were news to me. Elena, you raised a very important issue about the equivalence of treatment and operational research in penitentiary system and in the civilian sector, but it's a complex issue. The legislative framework or legal aspects of all that. What can be done here? Maybe we should come up with a legislative initiative, maybe at the State Duma or the Ministry of Health. What is your take on this issue and its solution? And the question to Dr. Dadu, if time allows. Thank you for such a good question, Olga. You absolutely right, saying that without legislative framework, we can't solve the issue. If legislative framework does not prohibit involvement of inmates in operational research, I will switch to English, but it will be simpler.
So yes, of course, you need to work on at the level of the regulatory frameworks, because of course you cannot implement a research if the national legislation forbids to do that. So and then you, of course, then I mean, I think it will depend on every context and every country on how to proceed and what entities and bodies should be involved. But I believe of course there is a role, absolutely crucial role of the Ministry of Health of the country to advocate for the amendments in the current laws and regulations, and national medical associations. I don't know now in how active and how much exchanges you have with the Russian Medical Association, who is a member of the World Medical Association, meaning adhering to all the declarations which are adopted by the World Medical Association, including Declaration of Helsinki, meaning, I mean, because the process in WMA is that any declaration is adopted with the consensus, so it should be, I mean, absolutely, 100% of votes of the members for a statement or a declaration. That means in Russia, the Russian Medical Association is fully agree with that. So I think it should go from all the entities who are health medical associations to advocate for the change and amendment in the law, and then to embed it in the regulations. I don't know if I answered your questions, because I think it's you already, I guess, had the same answer.
Yes, thank you. Now it's clear how to act further. Thank you, Olga. If you don't mind, let's switch to questions to Yelena after or during our Q&A session. And here, let me pass the floor to Dr. Irada Mammadova, who is the head of the training center on TB control in prisons in Azerbaijan, and she will tell us how to fight TB in the places of detention, and she will present an example of how to perform operational research in the penitentiary system. Irada, please, the floor is yours. Good day, dear colleagues. I would like to thank the organizers for the opportunity to share the presentation. I will try to start sharing my screen. Elmira, unfortunately,
Вот видим, да.
My presentation is a logic continuation of the presentations made before. I would like to tell you about the TB control services in the penitentiary system in Azerbaijan. First, I would like to give you some background information about the medical or healthcare services provided to the inmates. And I would like to acquaint you with the directions of TB control program. And I would like to tell you about how we manage TB cases and the results of our work, and I would like to describe the operational research itself. I would like to say that healthcare and healthcare to all the staff working in penitentiary system are provided by the main medical department. All the inmates, and we have panel institutions and preliminary detention centers, and we have a general hospital, and we have specialized hospital for TB patients within the system. All the inmates have full access to the whole scope of healthcare services and in pretrial detention and in panel institutions. We have medical departments which can provide primary health care and ensure medical examination and checkups. And we have also beds. If there are diseases, all inmates are referred to a healthcare facility, a general hospital, and if TB is suspected, patients are referred to a specialized treatment facility.
On the slide, you can see the main directions of our TB control activities, which start with detection. This kind of detection can be done at the detention centers or prisons, and within 24 hours, we ensure screening for tuberculosis. We use a comprehensive screening algorithms, which is used in the specialized treatment facilities of the penitentiary sector. Those patients who do not manage to complete their course of treatment continue their treatment in the civilian sector with the support of the NGO. In all our healthcare facilities, we ensure all infection control measures. I would like to say that at present, the incidence of tuberculosis went down by 38%, and the mortality rate went down by 50% compared to 2015. TB detection in the penitentiary system is done in three parallel sets of activities. That is screening at the admission to the panel institutions. It can be done within the first 3 days after the admission. It means that we collect patients' history, get the information about the symptoms and signs of tuberculosis. All newly admitted inmates have their chest radiography done, and expert examinations if needed. So as I said, during mass screening, we use questionnaires, implement clinical examination, chest radiography examinations, and in the presence of clinical manifestations, we perform culture tests on liquid and solid media. We also implement screening by request, and as I said, all inmates have access to the healthcare services in the penitentiary system, and for inmates with clinical symptoms of tuberculosis, screening by request can be organized if needed. So that request can come from inmates, medical staff, and penitentiary system staff. For this kind of screening, we use questionnaires, implement clinical examination, and expert MTB or RIF ultra tests. In case of positive test results, a complete algorithm for detecting TB is followed. And I would like to say that with meth screening, we ensure basically 100% of coverage with the screening activities. Same is applicable to screening at the admission because it plays a very important role in prevention of tuberculosis. And all staff members of the penitentiary system receive regular training and regular informing of our staff about tuberculosis helps us achieve good results. In our TB laboratory service, we have level 1 laboratories. They are located at the detention centers and in one mixed time facility. And in the general healthcare hospital. There we implement microscopy examinations and expert tests. At level 3 laboratories at the specialized treatment facilities. Our lab specialists confirm the TB diagnosis using molecular genetic tests, culture and DST tests on liquid and solid media. And they also ensure TB treatment monitoring. In 2019, with the technical support of the WHO experts, a new building of the level 3 laboratory was equipped and put into operation. Level 1 laboratory is also engaged in TB treatment monitoring. Specialized TB treatment is organized at the specialized treatment facility, and this is the optimum model because it has a number of benefits. All patients that are admitted to our treatment facilities are being carefully segregated based on their bacteriological status, resistance profile, treatment phase, and custodial control. We use adequate algorithm for examination, and when all results are available, we present cases at the meeting of the medical consilium. TB treatment at our facilities is being properly observed by the medical staff. And so depending on the bacteriological status and the resistance profile, we hospitalize our patients at the inpatient specialized facility, and it helps us ensure proper management of tuberculosis and proper management of adverse reactions. We have drugs available for treatment and for management of adverse reactions. Our department for sputum positive patients are equipped with the proper ventilation system. We organized regular training courses for physicians, nurses, and the staff of the panel institutions. Our statistics shows that annually up to 20% of TB patients are being released from the specialized treatment facilities without completing the course of treatment. And since 2009, released individuals have been tracked in collaborations with ICRC and NGO to complete their TB treatment. And now we can say that the number of treatment interruptions went down from 92% to 3% only. I would like to say some words about the infection control measures. Well, naturally, in all treatment departments of our specialized treatment facility, we closely follow all requirements of infection control. And we know that the basis for proper infection control is the administrative measures, which include early detection of TB cases, isolation of individuals with positive test results, and separation of patients' flow. I would like to say that between the detection of cases and enrollment of those patients for treatment, we have no more than 5 days. For smear-positive patients, we have supply and exhaust ventilation in place. We have UV lamps in those departments, and in 2019, we got a new building for XDR-TB patients with single rooms for the patients with proper supply and exhaust ventilation in place. Of course, we use all required respiratory protection equipment, but I would like to draw your attention to the fact that we ensure health promotion sessions and health education sessions organized for the inmates and for the staff. They are organized by the healthcare staff of our special treatment facilities. I would like to say some words about management of COVID in the penitentiary system. And as you know, nowadays, this is the priority activity for many of us. And before we started having COVID-19 patients, we did a lot of preparation for treatment of those cases. And we allocated a special building for COVID-19 patients. We also allocated the medical staff that provides treatment of COVID-19 patients. Currently, because of all these actions, the epidemiological situation in the penitentiary system of Azerbaijan is stable. And management of patients with coronavirus is in line with the national protocols and the recommendations of the World Health Organization. Statistics shows that inmates who have COVID-19, in 16% had the history of tuberculosis. Of them, 7% had active tuberculosis. Patients admitted at the specialized treatment facilities have COVID-19 tests done. And more than 6% of them had COVID-19 detected at the admission, and of them, 50% of patients had confirmed active tuberculosis. It means that those patients received treatment of COVID-19 and tuberculosis. Here you can see treatment outcomes of drug-susceptible tuberculosis and drug-resistant tuberculosis. As you can see, successful treatment among patients with drug-susceptible tuberculosis is at the level of 96%. And in the group of patients with drug-resistant tuberculosis who received second-line drug treatment was at the level of 92%. Here you can see the trend to a decrease in TB incidence and mortality. Since 2005, TB incidence reduced by 5 or 6-fold, and TB mortality went down by 17-fold compared to 2005. We applied to the Ethics Committee in September of 2020, and our operational research was endorsed. The geographic coverage included Baku, Sumgait, Absheron, and the penitentiary system. Initially, we planned to enroll 200 patients throughout the country. Of them, 10 in the penitentiary system. At present, the actual number of enrolled individuals throughout the country is 101, and of them 16 were enrolled from the penitentiary system. I would like to highlight the importance of the presentations made by Elena Leclerc, who said that it is difficult to ensure proper care at the penitentiary facility and to find that balance between the benefits of treatment and proper
It's very difficult to guarantee a lack of risk. But at the same time, we need to strive for maximum benefit and minimum harm. And when enrolling our patients, we've talked with them and we provided full information about the research to them. It was explained to them that they had the right to refuse. We received the informed consent, and we gave them sufficient time to think everything over and make decision. And I should say that none of the people whom we approached refused, and was quite opposite. They were enthusiastic, and they all agreed to be enrolled because the shorter treatment regimens are a huge benefit. As of today, there are 9 patients on treatment. Within the operation research, 7 patients completed their course of treatment with the preliminary outcome cured. 2 patients are still on treatment and they continue treatment in the civil sector with the support from the NGOs. And we've seen that in 64% of patients, we had conversion at day 1, and in 29% of patients, the conversion was received by month 2. No defaults, no reversions were notified. I would like to say that all bacteriologic and biochemical tests for treatment monitoring were performed on a monthly basis. Because of the stringent quarantine measures in the country, within the collaboration with the Scientific Research Institute of the Lung Diseases, all bacteriologic and biochemical tests for the patients enrolled in operational research were performed in the lab of the specialized treatment facility. During treatment, 2 patients had anemia, which resolved after corresponding treatment, and all the values became normal and the nasal dose was not changed. Closer to the end of chemotherapy, 3 patients had polyneuropathy. We've invited a consultant neurologist, and the dose was reduced to 300 milligram. And 1 patient, unfortunately, was left with irreversible polyneuropathy. A few words about our collaborating center on TB control in prisons. Our center performs regular trainings, both local, for the staff of the medical department, for other workers of the penitentiary system. We also perform trainings for the members of the Ministry of Health. We also work with the ICRC, performing trainings on psychological health and mental health. Our center has been added to the register of the e-health, and all the trainees can receive the credits. And starting last year, COVID-19 has been added to the agenda of the trainings in penitentiary facilities. We perform trainings on all new recommendations on TB prevention, diagnosis, and treatment, and the foundation of all our trainings is the new recommendations. And with my final slide, I would like to express my hopes in a better epidemiological situation next year. I hope that we'll be able to deliver an international course, maybe in May, June, on the global TB control and strengthening TB control in prisons using new drugs and treatment regimens. All the information is published at the website, and we would like to see you at the training next year in Baku. Thank you very much for your attention. Thank you, Irada, for such a interesting presentation. I would like to say that since 2011, the training center in Azerbaijan has been a center, as a collaborating center on TB control. It has been assigned an international status. And I would like to thank Irada for showing how to ensure proper TB control in the penitentiary system and how to reach such outstanding results following the latest WHO guidelines. And I'm very grateful for this innovative approach of the non-invasive treatment provision to the patients. And this is the cause of such good results. More than 90% cure is a very good result. We have questions, and I remember that we had two volunteers to ask questions before Irada's presentation. Aktai Gazalov. Aktai, please, if you are still willing to ask your question, it's time to unmute yourself. Olga, you wanted to ask a second question, please. If you want, I would like to give you the floor. Thank you, Elmira. A very good report, and we are well acquainted with the collaborating center. If I'm not mistaken, it was the first collaborating center in the WHO region on the work in the penitentiary system, and the results are really outstanding. Unfortunately, because of a technical glitch, I didn't hear the full report, but I had a question to Andrei Dado, and I addressed it in the chat. If you have time, maybe Andrei will answer it. Andrei, please. I don't see the question in the chat. The question is on the work published, on the report. What are the priority risks? What are the priority risks for the detection of active TB in the penitentiary system? What would you rank as the top priority? The status of a question, a detainee or a convict, is a risk factor in itself for the infection or the progression of active disease. This category of patients is subject to the groups for systematic screening. So inmates, detainees are and should be subject to mandatory regular screening. The algorithms are available in Module 2 of the consolidated guidelines. In prisons, depending upon the resources, 3 algorithms are used. Algorithm number 1 is symptoms-based, followed up by full X-ray into planes once or twice a year, and an algorithm with lab confirmation, either by microscopy or culture. Other methods of diagnosis can be used if the patient has immunosuppressed status, such as HIV or any other immunosuppressive conditions. Then IGRA and LEM tests are recommended. These category of patients with immunosuppressive status, but we see that in the Russian Federation there is a risk of active TB progression is 25 times higher than in the general population. In Slovakia, it is even higher, but on average, it's about 18-fold increase in the risk. But it's very difficult to segregate further among the inmates into additional risk factors because systematic screening performed once or twice a year is already mandated in that group as an active form of TB detection, intensified case funding. That's one. As for passive case funding, then it's a rule of thumb that all inmates they should be provided with health care, or at least they should have a right to seek medical care if they are showing the main symptoms of TB. Therefore, we need to perform some awareness-raising work among inmates. They should be informed about TB symptoms. They should be vigilant, and if they observe symptoms between the systematic screenings, then each inmate has a right to seek medical care, and the physician in the penal facility will manage him or her based on the diagnostic protocol. And this systematic screening is performed during the staying in the places of detention, and we know the standard. When a person is first admitted into the penal facility with the first contact of the convict, and during the transfer between the penal facilities, a mandatory medical check-up is performed, which should also include chest X-ray and symptomatic screening or survey to detect key symptoms of tuberculosis. Thank you, Andrei. Thank you, Olga. We have very little time left. I will be able to voice only one question before I pass the mic to Alexander. A question to Irada from Salgat. Not by Salgat. Huriya Hisanova, who follows up or who monitors screening? Are there any reporting forms? And what is the connection with the civil sector in Azerbaijan? Irada, just very briefly, 2 minutes. If you would like to answer in more details, please do it in writing. I wanted to say that Screenings are controlled by healthcare workers who directly report to the Ministry of Justice. The Ministry of Health is not involved in screenings performed in the penal system. Our collaboration is through continuation of treatment after the release. And one of the examples of our collaboration with the Ministry of Health is that within the operational research, to ensure sustainable continuation of the operational research, all the patients when switched to the civil sector, they undergone all the tests in our specified specialized treatment facility. We, as you might know, have some issues with the reference lab.
Для продолжения лечения, для мониторинга лечения.
So for continuation of treatment and for monitoring of treatment, we do what we can. However, a screening was not included. I hope I was able to answer this question, but perhaps I misunderstood it. Thank you, Irada. Since we ran out of time of our webinar, we will answer the questions from the chat in writing and will send the answers to all the participants. Now, I would like to give the floor to Oleksandr Korotych from WHO Euro, who will update us on the status of the regional operational study. Thank you very much, Elmira. I'll be very brief, and I will tell you about our current achievements and about something that we focused on during the past months. More than 2,200 patients were enrolled for treatment with the shorter treatment regimens in the framework of our research project, and 7 countries completed the enrollment of patients in their cohorts. We also encourage countries to establish country cohorts and to approve the protocols at the ethics committee and to continue follow-up of the patients and treatment of patients in the country cohorts. In the WHO working group on shorter treatment regimens, we talked about the potential changes in the country protocols in order to reflect our experience in collaboration with the countries. We have already introduced a number of changes, which included a possibility to include patients who received treatment with the drugs included in the treatment regimens if they received that treatment for other diseases and not for TB if they have susceptible tuberculosis. We also considered a possibility to use bedaquiline and elamanid in children after the WHO guidelines for the new doses become available. We prepared these protocols in Russian and in English, and then we will send them to the countries for adaptations. They will be able to use them when their country cohorts are approved. So we worked with Belarus, and 215 patients enrolled in the framework of the country cohort to include them into the regional study. So we increased our regional cohort by 250 patients, and which is very good. We can analyze treatment outcomes and to increase the strength of our results. We also would like to make a preliminary announcement. At the beginning of March, we would like to have a regional event of the regional teams that participate in our research study in order to discuss the current progress, lessons learned for the future initiatives. And we'll be very glad to see you all in March in the framework of this meeting. Well, that is all I had to tell you at this moment. Next week, we will send you a package of the updated protocols for the national adaptation that you will be able to use them for your national cohorts. Thank you very much, Alexander. And now I would like to give the floor to Askar Yedilbayev, who will close our session. But before I do that, I would like to thank all our presenters. Thank you very much for your hard work, for your presentations, and thank you very much in advance for written answers to the questions that will be circulated among the participants. Thank you very much, Elmira. Thank you very much, dear presenters and the audience, for finding time to join our 11th Virtual Medical Consilium meeting organized by the WHO Euro. Of course, this topic is very topical for us, and it touches the issue related to the operational research studies and also the issues of equality and access to adequate healthcare treatment that is offered in the framework of the operational study in the civilian sector. It is also very important for the patients in the penitentiary sector. So all of that should be done with respect to ethics and legislation adopted in the country. We, as the representatives of the World Health Organization, would like to say that our motto is to leave no one behind. This is the priority for us, which means that we need to ensure equitable access to advanced methods of treatment, even if it happens in the framework of the operational study. We know that the enrollment of patients to the regional cohorts for treatment with modified shorter treatment regimens, and if you have a possibility in your countries to enroll patients from the penitentiary system, you need to consider that possibility. And we, as the World Health Organization, can provide some assistance to you in this respect. I also would like to say that treatment of patients in the penal institutions and collaboration of the civilian sector and the penitentiary sector goes beyond the framework of this webinar. And the fact that we received lots of questions means that this is a sign for us to organize some additional meetings to discuss these issues and to give a possibility to exchange the experience between the participants. Since our virtual medical consilium demonstrate its success, and it helps you in your everyday practice, we receive a number of requests. Not all healthcare workers in the countries can join these webinars. And so starting next year, we plan to organize country webinars of the Virtual Medical Consilium. For example, we received requests from Ukraine, from Kazakhstan, and we can plan and organize regional medical consilium meetings for one or several countries. And our goal is to provide your with the necessary support for proper management of your patients. Thank you, and I'm wishing you all the best. Thank